welcome again to another session on the January 2026 RRR series from StudyMEDIC. So today we're going to do a very interesting topic in data interpretation, which is understanding hepatitis B and VDRL serology reports. So we've seen in the exams and also in our clinical practice that serology questions are rarely about memorizing. So they test whether we can interpret patterns, avoid false positives, and decide what to do next, especially when the patient is pregnant. So this image is our message for today. A closed mind is like a sealed jar, and no matter how much wisdom you pour into it, nothing new can enter it. But when you stay open, curious, and willing to learn, you create a space for fresh ideas, new perspectives, and endless possibilities. Every new lesson opens the door to even greater understanding, and that will turn your journey into a continuous cycle of improvement and self-discovery. So keep your lid open, stay teachable, keep evolving, one insight, one lesson, and one step at a time. So today's session is actually not going to be anything new. We've all gone through these serology reports, and we just are going to train ourselves to avoid silly mistakes in the exam. By the end of this session, we should be able to interpret common hepatitis B serology patterns, distinguish between active infection, immunity, and window period, correctly interpret VDRL results, including false positives, and most importantly, decide the next step in management. Now, before we move on to interpreting the results, we must be sure about what the hepatitis B virus markers are and what they represent. So firstly, the most important one, the one that we always do in our clinical practice, is the surface antigen or HBsAg. Now, this is an antigen which is produced by the hepatitis B virus envelope or surface, and it is detectable in the serum from 40 to 160 days post-infection. And presence of this antigen indicates that a patient has HBV infection. Then we move on to the surface antibody, which is anti-HBs. Now, antibody is produced by the immune system in response to the exposure to the surface antigen, and it includes response to hepatitis B virus vaccination. Now, normally this is not detectable in infected individuals because there are immune complexes which are formed with the surface antigen. However, this can be used to assess response to hepatitis B virus vaccination. Then we have the anti-HBc or the hepatitis B core antibody, and it has two forms, IgM and IgG. Now, antibodies produced are in response to the virus core antigen, and it indicates viral infection at some time, and once produced, it remains lifelong. In the absence of surface antigen, presence of anti-HBc suggests that there has been past hepatitis B virus infection and latency of hepatitis B virus. However, presence of hepatitis B surface antigen along with this antibody indicates chronic HBV infection. This antibody passes across the placenta, and maternal anti-HBc detectable in infants up to 15 months of age. Now, what is IgM anti-HBc? This is the antibody which is produced by the immune system in response to the exposure to core antigen, and it indicates acute infection. Now, the same antibody but in the IgG form represents past exposure, but it is never present in post-vaccination patients. Then we have the HBe antigen or HBeAg. This is a marker of active viral replication, and it is usually associated with high hepatitis B viral load. So the antibody to this, anti-HBe, is obviously produced by the immune system when it is exposed to HBe antigen. and it is usually associated with lower viral loads, but that is not confirmed. It is not always the case. The viral load is checked by HBV DNA, which is quantitative level of the virus DNA, which is detectable in the blood. It is measured in international units per ml. Then we have the quantitative HBs antigen, which is measuring the titer of surface antigen in blood, and it is a good guide to indicate the treatment. So now let us try and see certain combinations of the hepatitis B virus serology patterns that are given in the exam. And what happens is we tend to panic when we see these kind of questions. But what we need to understand is that these patterns are predictable. So let us go through a few patterns and see what we can infer from those reports. So if in the first scenario, the hepatitis B surface antigen is positive, we need to think of current infection. And if it is positive with IgM anti-HBc, then we are dealing with an acute hepatitis B virus infection. If the core antibody is positive, but it is IgG type, and there is hepatitis B surface antigen which is detected, but the surface antigen antibody is not detected, then we are dealing with a chronic hepatitis B virus infection. So please note, IgM comes in acute infections and IgG is present in chronic infections. Third case scenario, where the surface antigen is negative, the core antibody is positive, and the antibody to the surface antigen is also positive. So this means that the infection is resolved and the patient is now immune to this infection. The next scenario is hepatitis B surface antigen is negative. The core antibody is also negative, but there is an antibody to the surface antigen which is present. So this implies that the patient is vaccinated. Now, another very tricky scenario in the exam is when the surface antigen is negative, the surface antibody is negative, but the IgM core antibody is positive. So what would this mean? This means that the patient is in the window period. So the window period is when the infection has not been actively detected, but the antibody has started to form. So this is another scenario that can be given in the exam, and one must be aware of the findings. So when a patient comes in for her booking visit in pregnancy, we offer her certain screening tests and she has to consent to those screening tests. So now for this presentation, we are assuming that the patient has given her consent for screening and she comes out to be hepatitis B virus positive. So in pregnancy, interpretation is only not enough. We need to act on the report as well. So once the HBsAg is positive, we must check the HBe antigen and the viral load or the HBV DNA to assess infectivity. We must also assess the HIV status, HCV status and hepatitis delta for a co-infection possibility. Positive results need to be notified to the GP, the health visitor and the child health information system to ensure neonatal follow-up. A high infectivity, that is HBe antigen positive and high viral load, that means that the patient will require maternal antiviral therapy and the drug of choice is tenofovir disoproxil or TD for short. Also at the same time, the CHIS has to be informed and neonatal vaccination along with hepatitis B immunoglobulin will need to be given to the neonate post-delivery. In cases of low infectivity, we need to give the neonate vaccination within 24 hours of birth. Breastfeeding is allowed in patients of hepatitis B, and all patients who have hepatitis B in pregnancy should be followed up at 12 weeks or 3 months so that they can be assessed. Next, we move on to syphilis, which is another favorite for the MRCOG exam. And although it seems like a trap, it really isn't. So there are two types of tests that we do for syphilis. Firstly, we do the non-treponemal tests, which are VDRL and rapid plasma reagent tests, and the others are treponemal tests, which are the TPHA and FTA-ABS tests. Now, the first thing that we need to know is which test is for screening and which is for confirmation. So the non-treponemal tests, they are used for screening, and once they come positive, then we move on to the treponemal tests for confirmation. So VDRL is a screening test, and it gives titers like 1:2, 1:8, 1:32, like that. It can be false positive and is used to monitor treatment response. Now, treponemal tests are confirmatory, and once positive, they will remain positive for life. VDRL can be falsely positive in conditions like pregnancy, autoimmune diseases like SLE, TB, malaria, IV drug use, and even after recent vaccination. So that is why in pregnancy, a positive VDRL must always be confirmed using a treponemal test. Now we come to the interesting part of interpreting the results. So if we are given that the VDRL test has turned positive, and then a treponemal test was done, which is the TPHA, and that is also positive, this confirms that the patient has true syphilis infection. In the next scenario, the VDRL is positive, but the TPHA is negative. So this implies that there is false positive reaction to VDRL. If the VDRL is negative but the TPHA is positive, this implies that there is some past treated infection. Which brings us to a very important exam concept of serofast state. Now, before we move on to understanding what is serofast state, let us go through the various stages of syphilis and how we can know that the syphilis is early, whether it is recent or whether it is late. Now, active syphilis, which is untreated, will present with a positive VDRL in high titers. So the titers may be 1:32 or 1:128, like that. The TPHA is positive, and like we discussed, the TPHA, once it becomes positive, it will remain positive for life. Now, if the VDRL is positive but in low titers, which on follow-up, if we follow the patient up, it will rise over weeks. This means that the patient has had recent infection and the TPHA will be positive. In treated syphilis, the VDRL titers start falling and sometimes they become negative. So they will go below 1:4 and the TPHA remains positive. Now we come to a condition called the serofast state, which is actually becoming an exam favorite. Now here what happens is that the VDRL levels start falling after adequate treatment, but they do not become negative. They actually plateau at a low level and go below 1:4 and sometimes 1:2. But there are no symptoms, and this does not imply reinfection. This is not treatment failure, and this does not require treatment. So this is known as the serofast state, where the levels of VDRL are plateauing. Then there is the late syphilis, in which the titers of VDRL might be negative or low and the TPHA remains positive. Now there is a time or a condition in which the VDRL levels on follow-up rise fourfold. So when this fourfold rise is seen in VDRL titers, this implies that there is reinfection in the patient. So this is about the various stages of syphilis, and it is very important to understand the serofast state. So it is important to understand the management of VDRL in pregnancy. If the VDRL is positive in pregnancy, then we need to confirm with TPHA, and once it is confirmed, then we need to start treatment with benzathine penicillin, and we should not delay the treatment. We should also do a partner checkup and treat the partner as necessary, and we need to follow the VDRL titers to assess response. In pregnancy, the treatment should not be delayed. Now let us discuss a few questions and see what the scenarios in the exam can be given as. And once we know the various markers and how they behave in a situation in an infection, we will be able to answer the questions without panicking and without getting confused. So here goes. Now there's a 12-week pregnant missionary worker, and she has come to you, and the test that you've done, the VDRL is reactive and the TPHA is non-reactive. So how would you interpret these results? A, active syphilis, B, past treated infection, C, biological false positive, D, this is early seroconversion, or E, is it a mixed infection? So what do you think this would be? VDRL, the screening test, is reactive and the confirmatory test is non-reactive. So this is a biological false positive report, and non-treponemal tests can be false positive in pregnancy and autoimmune states when the confirmatory treponemal test is negative. Other conditions where biological false positives may happen are given in this list. Now there's a 29-year-old woman. She is 18 weeks pregnant and she had a VDRL titer of 1:128 a year back, and she was diagnosed with syphilis. So there was a confirmatory test done and she was diagnosed to be syphilitic. She was treated with benzathine penicillin G 6 months ago, and her VDRL titer decreased to 1:2. Currently, her VDRL titer on follow-up remains 1:2, and her treponemal test TPHA is positive. She has no symptoms. So what is the appropriate interpretation of her current syphilis status? Is it active syphilis, which will require treatment? Is it treated syphilis with an appropriate serological response? Is it reinfection with syphilis? Is it a serofast state, or is it a false positive VDRL test? Now let us see what we are dealing with. So this is a typical serofast state where there is persistent low levels of VDRL. Now this patient's VDRL was appropriately falling, but it has not fully reverted to negative and it has plateaued at 1:2. So there is no reinfection and there is no progression. So this kind of serofast state occurs in around 15 to 20% of treated patients, and the VDRL may never revert fully to negative. This is not an active infection and there is no need for retreatment. So there's now an Asian woman who has come in her third pregnancy and she is at 12 weeks of gestation. She has recently moved to the UK from Thailand to be with her new husband. After pre-test counseling with the aid of an interpreter, she agrees to hepatitis B virus screening, and the result is given as below. So the surface antigen is positive, the core antibody is positive, the core antibody IgM is negative, and the surface antibody is also negative. So what is the significance of these results? Is it post-vaccination? Is it a resolved infection? natural hepatitis B virus immunity? Is it a chronic infection, or is this an acute hepatitis B infection? So what do you think this could be? Let's go ahead and see. So the interpretation of the serological result, the hepatitis B surface antigen positive, means that there is presence of the surface antigen. So that means there is some ongoing infection, whether it's acute or chronic. Now we have the core antibody which is positive, so which suggests that there was some past or current infection with hepatitis B. The core antibody IgM type is negative. So this rules out a recent or an acute infection, and if this was positive, then it would have been a recent infection, but this is negative here. Then we have the hepatitis B surface antibody, and that is also negative. So this indicates that there is no immunity from recovery or vaccination. So this result is typical for a chronic infection. Now, why is this not post-vaccination? Because in post-vaccination, the anti-HBs or the antibody to the surface antigen would be positive and the surface antigen would be negative. So this is not post-vaccination. In resolved infections, again, this would show the surface antibody to be positive and the core antibody to be positive along with the surface antigen negative. So this is not resolved infection. A natural hepatitis B virus immunity will also show the antibody to the surface antigen to be positive and the core antibody to be positive along with the surface antigen negative. Finally, why is it not an acute hepatitis B virus infection? Because the IgM type of core antibody will be positive in an acute infection along with the surface antigen positivity. So this is how step by step you see what the viral marker levels and the reports are given, and then you finally decide which type of infection you are dealing with. Finally, to summarize some key points, the surface antigen positive means that there is current infection. The surface antibody alone will mean that the patient is vaccinated. And if there is core antibody IgM alone, then this means that the patient is in the window period. In VDRL, in syphilis, the VDRL test is used for screening, and the confirmatory tests are treponemal tests like the TPHA. FTABS is no longer done in the UK. Falling VDRL titers implies that there is a good response to treatment, and serofast syphilis means that there is persistent low-level VDRL titers below 1:4 with no active symptoms or active disease. Now, I hope this has been useful for you and you will be able to solve the hepatitis B and VDRL serology with greater confidence in the exam. So thank you all for going to the session, and we'll see you in the next session very soon.